name is Sandy Hassink, and I'm the past president of the American Academy of Pediatrics. So, good afternoon, everyone, and I'm delighted to be invited to this conference, and I do have to admit that it was with some insistence on the part of Shale Wong and myself that children needed a voice, and I'm looking straight at you, Andrew, that we got a space on this platform because I think this, and I'm going to tell you a story. I'm on an IOM committee studying obesity trends, and it's a wonderful, wonderful committee, and we have measurement and evaluation people, and we're talking about global population trends, and we got to discussing some populations that were left out of this trend data, and rural populations and populations in poverty and our Native American populations, and that all the people on the committee said, and of course, the 0 to 2, children 0 to 2. And what I'll tell you is 0 to 2 is not a subpopulation. 0 to 2 is the population, okay? And so I'm here to sort of help you remember that 0 to 2, 0 to 5, 0 to 21, that is the population. And upon that childhood population is where we are going to build or not build the foundations of health. So I want to start out by just telling you a little bit about how the children are, and I like to start with this because I think we need to be grounded if we are going to have a responsive healthcare system and be responsive providers. I think we need to be grounded in what's actually happening out there and what's actually happening to the children. So you can slice and dice this conversation many different ways, but I want to focus on mortality. What are children dying of? What is the morbidity that we are seeing in childhood, which revolves around chronic disease and risks for chronic disease? And then what kinds of things are now beginning to threaten the foundations of health? So the leading cause of death in children birth to 24 years is still injuries, unintentional injuries, homicide, suicide, the complications of prematurity, and SIDS, congenital anomalies, cancer, cardiovascular, respiratory disease. And embedded in those unintentional injuries and homicides and suicides is the epidemic of violence we are experiencing in this country. So while we're here talking about quality measures and payment and sort of interference in our practice, I just want to tell you that in Florida there's a law that prohibits physicians from asking families if there is a gun in the house, and we are asking those families for the purposes of counseling on gun safety. We are now prohibited from asking that question. That is in appeals. We think it may have to go to the Supreme Court before this gets resolved. So I just want to open your eyes to some of the wider influences now on being able to practice medicine that addresses leading causes of death in children and being able to even merely ask the right questions to elicit that information. And also embedded in this statistic is the culture of violence, the cyber violence and bullying and teasing. And so what the children need is the children need not to be being born into and living in a culture of violence. Now, what are we seeing in morbidity in childhood? Well, we're certainly seeing the acute illnesses, but our wonderful immunization programs have virtually eliminated many of the acute illnesses we used to see, but we are seeing the rise of non-communicable diseases, or globally, if you were talking about it, or the rise of chronic illness. And food insecurity and obesity, if you added overweight to that, that would mean 50% of the children in this country have some significant nutritional problem. Developmental disabilities, again, complications from premature birth, asthma, low birth weight, depression in children and adolescents, and behavioral issues. So we are seeing the rise of the chronic morbidity, not just giving us risk in adulthood, but actually impacting the current state of child health. And we have to have a system that is responsive to dealing with these chronic morbidities and the risk for adult health. And here you see the threats to the foundations of child health. And these are national data. So if you boiled this down to regional or even county level data, you would see embedded in this data much higher rates in certain of our vulnerable and minority populations. You heard me say 50% of children are not meeting federal dietary quality standards. 18% of our children have obesity, but if you look in minority and vulnerable communities, it's 30 and 35%. Food insecurity, we literally have an epidemic of food insecurity among our childhood population. 21% of our children live in food insecure families. 9% of our children have activity limitations that are significant based on some other chronic illness. 5% of parents are reporting significant behavioral or emotional or mental conditions in their children. And I think we should all pause and take a deep breath when we know that 8% of our teenagers have experienced a past year major depressive episode. We know very well that early childhood care and education is a major health determinant later on. Children that receive quality early child care and education, especially our most disadvantaged children, have higher graduation rates, lower incarceration rates, better overall health, better jobs and incomes, and yet more than half of our children in this country do not attend even any early education. And we recently released in the last month a statement on poverty and health, and almost half of our children under 6 live in communities, live in families 200% or below the poverty level. And 11% of our children live in families under the 50th percentile for poverty, and poverty is a major driver. So this is a snapshot of what is happening to children, and I would say that whatever we do here, whatever we talk about, we must be responsive to what is actually happening to our population of children. And so one way to frame this, and I've been going around this last year in my year as president, talking about the Harvard Center for the Developing Child framework for thinking about the foundations of health, which is a goal for every child in the country, the entire population. Sound and appropriate nutrition to remediate food insecurity, overweight, and obesity. A stable, responsive environment of relationships, and this invokes all the things we now know about toxic stress. The relational health element that embeds stress in the biology of a child and relates it directly to adult chronic disease, and the need to both identify the stressors and remediate it with building resilience in families and patients. And you don't have to look any farther than Flint, Michigan to see the importance of a safe environment for our children to grow up. And there's a whole cohort of children now that will not achieve their development, their potential unless very strong remediation is put in place, and even then will not achieve their cognitive potential based on the lead contamination in Flint. So, I'm often asked, so Sandy, what do they want? What do the pediatricians want? And what the pediatricians want is to get paid for doing what the children need. That's what we want. And I think that's what we're here to discuss. And I think it boils down to that. If we paid the pediatricians for doing what the children need, I think we would have less burnout, we would have less dissatisfaction, that we would be aligned with what our hearts tell us the children need. And so healthcare delivery is only as effective as the payment and the structural elements that exist to facilitate that care. And we all have heard over and over again how fragmented and insufficient payment and structures result in suboptimal care. So when we look at building the foundations of health, I think there are several components. Building those foundations are longitudinal. It takes place over time. It starts before birth. It continues throughout childhood and into adulthood. There's a developmental component, because how you build these foundations in a family with a 1-year-old is different than how you build them in a family with a 15-year-old. Family focused, and we'll talk in a minute about the importance. Obviously, we're adult educators. We work in the context of the family. So why aren't we using the family as the unit of return for investment in healthcare? And how many times do we talk to the family about improving the child's health status, and the whole family's health status improves? Where is our return on investment when we look at families? And it's cumulative. It has to happen over and over again to build these foundations, and certainly it's contextual. So longitudinal. In terms of payment models, we have an entire array of preventive service and anticipatory guidance outlined in Bright Futures. I think we need here to acknowledge what's actually happening there. This isn't just not some nice thing we're doing to provide some anticipatory guidance, and certainly the parents appreciate it in the moment. They want those problems solved in the moment and what to do with the 5-year-old who's tantruming, but we are building adult health. And we need an acknowledged link to what we are actually doing, and we need to link and stop siloing pediatric care from health care. So Bright Futures is a construct that supports longitudinal care, and in the Affordable Care Act, we were able to get the elimination of a copay for preventive services included in Bright Futures, which was a first step to sort of entrenching this kind of preventive counseling into some kind of a payment system that would work for children and adults. And we all know the developmental challenges here, and physically, mentally, psychosocially, These elements develop over the course of childhood. So if a family drops out of your practice for a year or 2 years, or you don't have a well visit paid for 2 years in teenage years, you miss key developmental steps and key physical changes. So we need a payment system that reflects the need to keep track of what's happening developmentally and the frequency of visits that makes sure that we don't miss key developmental steps or key physical conditions in children as they're moving along that continuum while they're still well, and not waiting for them to be sick or have a problem that developed in the 2 years that you were not able to see them. So we have a lot of visits in 0 to 5. We have 22 visits in 0 to 5, which is great. That's a platform, and we are probably the health providers for young children. That is our only platform in this country to deliver services to children where every child is seen and receives those services. It's a very valuable platform, but I would say we've dropped the ball a little as children age, and we are not keeping up with the frequency of touch points that they need to stay on a healthy, developmentally appropriate trajectory and to take care of all the risk behavior that develops. The family for us is the final common unit of health and healthcare delivery, and I talked a little bit ago about, for every chronically ill adult you hospitalize, there are people in that family that need early intervention and people in that family that need prevention. And for every child I saw in weight management and improved their weight, I improved their weight because the family changed and the family's weight status often improved. So where are we with thinking about the family unit as a unit of return on investment for some kind of healthcare intervention, because we know the family's health is crucially connected to the child's health. So, when I stood in clinic one day and watched a 13-year-old who had just developed type 2 diabetes being brought in by her mother who was blind from type 2 diabetes, you realize something dramatically wrong is happening to that family. Genetic predisposition, bad environment, poor health modeling, but it was all connected. The family's literacy and health literacy and skills to navigate the healthcare system dramatically impact the child. And how are we improving the whole family's ability to navigate their own health, to understand their own health, to understand what a quality encounter actually is? So I was at the pharmacy a couple months back, and a mother rolls up to the window, asks the pharmacist, and she has a 4 to 5-year-old in her arms, and she rolls up his pants leg, and she points to a rash on his calf, and she says to the pharmacist, "He has a rash." The pharmacist looks at the rash, and she goes, "Benadryl." The mother walks away. She's smiling, picks up a bottle of Benadryl. The pharmacist is smiling. She gave advice. The mom thinks she just had a healthcare encounter. Okay, not one question was asked about that child. Did he have a fever? Where else was the rash? Where else did he go to get care? Did mom realize what was happening? I don't know. She got an answer from somebody who was actually wearing a lab coat and thought this must be the answer. So our parents, our families, are not well educated to even understand what's happening to them within the healthcare system, and that has to be part of it. And the health of the family impacts the health of the child. So when we expanded Medicaid and gave adults care, we have data to show that when adults have insurance coverage, children do better with their own health care. So inextricably linked and contextual. And so those of you who know Vince Folletti's work on adverse childhood experiences, the more adverse childhood experiences you have, the higher rates of adult chronic disease, mental health, and problems you have, we know that those childhood experiences embed themselves and create poor adult health. And if we're not attending to that, we are not being responsive to what the children need. And multi-sector. We have to be sharing information across sectors. So when you have a 4-year-old who goes to a family daycare provider, then to daycare, then to preschool, then to an after-school program, then back to home, and you find yourself on your knees looking into the 4-year-old's eyes asking, what did you eat for lunch, and did you play outside today? And only the 4-year-old knows the answer to that question. Something's wrong with the healthcare system, because no adult knew everything that was happening to that 4-year-old that day. So we need to work across sectors, and we need every door that family knocks on to be a door that will be accessible to get the services in the community that they need, and they don't have to go to 5 or 6 places to get those services. So what do we need here? We need a payment system that is responsive to the needs of children and families. We need measures that reflect longitudinal outcomes. We need explicit acknowledged linkages that this care of the children is explicitly and obviously linked to our adult healthcare outcomes. We need the recognition that prevention, public health, and health promotion are core reimbursable activities. And we need to have research on the day-to-day impacts of the environment and of our interventions on the child and family health. So I'll end there, and thank you very much for your attention.